Good evening. I'm Kelly Geer Ripken, National Chair of A Women's Journey. On behalf of Johns Hopkins Medicine's A Women's Journey, thank you for joining me this evening for our monthly webcast series, Healthy Conversations That Matter. A Woman's Journey strives to improve your well-being through health education. Inflammation is widely considered the root of some of the most debilitating diseases, including cancer, heart disease, Alzheimer's, and diabetes. Tonight, we are joined by Johns Hopkins rheumatologist Lisa Christopher-Stine, who is professor of medicine and neurology and is the co-founder and director of the Johns Hopkins Myositis Center. So please use the Q&A on your screen to ask your questions to Dr. Christopher-Stine, who will respond during the last 20 minutes of our program. Tonight's webcast will conclude at 8 p.m. I want to take this opportunity to acknowledge and thank Johns Hopkins University's program, Hopkins at Home, for their production assistance. You can visit their website, hopkinsathome.jhu.edu, for additional lectures and courses throughout the year. A Woman's Journey acknowledges the support of the Waglicki Family Foundation, sponsor of Healthy Conversations That Matter. And now I am pleased to welcome Dr. Christopher-Stine.
Thank you so much for that warm introduction, Kelly, and hello to everyone. Good evening, good morning, good afternoon from wherever you're joining today. What a pleasure it is to be with you today. So I've been asked to speak with you about an update of inflammation in the body, a very topical topic. These are my disclosures. So tonight for me, I'll show you a mix of foundational knowledge of inflammation, as well as recent advances linking inflammation to chronic diseases that you're familiar with. And not all doom and gloom. I hope by the end of the talk, we can discuss what we might be able to do about all of this. So what will we review together? I'm going to take you to medical school and we'll talk about the cardinal signs of inflammation. I'll show you evidence for the role of inflammation in chronic diseases in everyday life, such as heart disease, cancer, autoimmune disease, where I spend my time thinking about disease states, depression, and even Alzheimer's. And as I mentioned, strategies to prevent and treat this inflammation. So what is inflammation after all? On the right side of your screen, you sort of see this lower back inflammation, but it can be anywhere in the body, of course. And the suffix, the medical term itis, right? So you heard that I am the director of the Johns Hopkins myositis Center. That's inflammatory muscle disease. I'm a rheumatologist by training, so I think a lot about itises. Inflammation is the body's natural defense mechanism. So it's defense against injury, infection, anything harmful in your environment. So it's not necessarily all bad. It can actually be good. Certainly when you stub your toe, you want to be able to repair this. And that's the body's defense mechanism. It can be external. So, right, you can see it. Obviously, of course, if you have a scrape or a cut and it becomes a little red around that area, that's inflammation you can see. The internal inflammation in our organs, a little bit tougher. But all of that inflammation really starts from cellular damage. How do we damage our bodies? Well, we have a lot of lifestyle issues and other habits that do this. So for heart disease, again, I'm not telling you anything you don't know. High blood pressure, poor glycemic control, so poorly controlling your glucose, or smoking are all ways that we cause cellular damage. For cancer, there is this idea that long-standing inflammation in one's organs can lead to cancer. There's examples of this, for example, in the intestine, where ulcerative colitis, unbridled and untreated, can lead to colon cancer. Certain types of hepatitis viruses can lead to liver cancer, and there are various other organs where this is true. So I promised you a bit of med school. So these are actually the very cardinal signs of inflammation, and I think you can see on the bottom of the screen, we've sort of known this since the first century. These are the Latin terms for inflammation: calor, rubor, tumor, dolor. We have heat, we have redness, we have swelling, we have pain, and that's a little illustration on the right to tell you that. And there's a little extra one over there called loss of function. That's often called the fifth sign of inflammation. How is all of that relevant? Well, stay with me. But we also have fever, chills, fatigue, lack of energy, headaches, appetite loss or actual weight loss, maybe stiffness and not quite feeling right. So those may also be signs of an inflammatory process that's not so easy to see. While acute inflammation is often protective, as I mentioned at the start of my talk, chronic inflammation is really what we'll talk about tonight. This is the contributory factor for the chronic disease states. So, as opposed to acute inflammation, chronic inflammation is not resolved over time, usually. It's characterized by this sustained production of what we call pro inflammatory molecules. These have detrimental actions on various organs in the body at the system level. And so there's plenty of phenotypes or types, right, of chronic inflammation. There's aging and immune senescence. I'll tell you a bit about dysfunctional mitochondria. If you think back to biology, remember that mitochondria provides a lot of power for the cell, and sustained oxidative stress can lead to these chronic states. Autoimmune reactions, obesity induced immune cell dysregulation. It turns out that obesity in itself is a chronic inflammatory state in which every fat cell, called an adipocyte, is its own little inflammation factory. So sometimes it's not about losing a lot of weight, although we often ask our patients to do this. For every bit of weight lost, you decrease your inflammatory burden just a little bit. And infections, they're no greater example than the recent past as COVID. How do we measure inflammation in our body? Well, it's the easy on the outside, right? An abrasion, infection, ankle sprain. As I told you, within the body, it's a little harder. So as rheumatologists and as physicians in general, some oncologists and other specialists, your primary care doctor, your cardiologist, may be thinking about certain blood tests to help measure that inflammation. Two of the main blood tests that have been around for a long time, and they are nonspecific. I want to be careful to say that, yes, these can go up during inflammatory states. If they remain elevated for a long time, we really do start scratching our head thinking about why they are up. That's something called an erythrocyte sedimentation rate. Doctors call it a SED rate for short, and a CRP, a C-reactive protein. Particularly, I'll tell you tonight about the high sensitivity CRP, which is more important when we talk about cardiovascular disease. So these are two inflammatory tests that we look for. So I talked about the SED rate. The good news is this is relatively inexpensive as testing goes. It's easy to perform. And it's really a test that occurs outside the body. So this rate that we're talking about isn't actually inside you. It is how fast the red blood cell, which is called an erythrocyte, that's where it gets its name, settles in a test tube over a period of time. So it's over an hour. So how many millimeters per hour? That number, that time, that will go up with certain things. Inflammatory states like infection, some cancers like multiple myeloma, lymphoma, things like lupus or temporal arteritis or rarer autoimmune diseases. And it's very nonspecific. So pregnant women can have an elevated sedimentation rate. So generally, it's more difficult to test in pregnancies because it's difficult to discern from an underlying disease versus the pregnancy. Aging itself raises it a little bit. It can be used to monitor disease activity in response to therapy. But elevations can occur with no localizing signs and symptoms that it's not always so helpful. Sometimes it's not elevated, even in some inflammatory conditions. C-reactive protein, on the other hand, tends to be more generalizable and tested more often. So I want to be clear that a sedimentation rate is helpful if you have a known inflammatory disease, like a ongoing rheumatic disease, rheumatologic disease, polymyalgia rheumatica, maybe even rheumatoid arthritis. We'll take a look at these inflammatory measures to see how well you are being treated and how much inflammation is present. In the general population, asking for an ESR or an erythrocyte sedimentation rate, not really so helpful, as it's fairly nonspecific unless there are localizing signs. So I want to be clear about that. C-reactive protein is a protein that's made by the liver in response to inflammation. And what CRP does is it binds to dying cells and it can bind to bacteria. And this activates part of our immune system that we call the complement system. And it provides this eating of cellular debris by white blood cells that are called macrophages. Macrophage or macrophage literally means large eaters, right? Phage is to eat. So it eats these white blood cells. And the CRP then rises as a result of the rise in something called interleukin 6. This is something called a cytokine. And normally you might say, boy, my audience has not often heard of the word cytokine, but I bet many of you heard that term during the COVID epidemic with cytokine storm. People are worried about cytokines, right? Which essentially means cell movement. So these are immune system proteins produced by white blood cells and fat cells. Remember, I gave you the heads up that not only white blood cells are these inflammatory cells, our own little adipocytes, fat cells themselves, can serve as those little factories of inflammation. This can go up in response to acute and chronic inflammatory conditions. So any virus, bacterial or fungal infection. I told you previously that the sedimentation rate goes up. In rheumatic and other inflammatory diseases, the CRP can rise as well. Malignancy or any tissue injury, necrosis, which literally means cell death. All right, should you have your SED rate or CRP checked? I told you that in the right context, yes. A suspected or known inflammatory condition, yes, for the sedimentation rate and probably the CRP. A high sensitivity CRP can measure very low levels of CRP. So this is looking for tiny levels. It's highly sensitive to pick it up, particularly useful in predicting the risk of cardiovascular disease. So the risk of developing cardiovascular disease is actually quantifiable. And if your high sensitivity CRP is under the level of 1, that's 1 milligram per liter. And there are different ways to measure CRP. It should be in the milligram per liter measurement. It's low. If you're somewhere between 1 and 3, your risk is thought to be average. If it's above 3, you have a higher risk for eventual cardiovascular disease. But I want to be very clear that this is not to be used alone. It is a combined composite measure used with elevated levels of cholesterol, particularly your quote unquote bad cholesterol, your low density lipoprotein, that LDL, your triglycerides, your glucose levels, your sugar, to determine this risk. So smoking, high blood pressure, diabetes can also increase that risk level for cardiovascular disease. So you have to have what's essentially called a pretest probability or a higher suspicion. In the right case, these can help modify your risk. And sometimes they spur you on to action because you feel a little scared about your risk and you'll modify them. So in summary, there's a cardiovascular risk assessment that says that elevated high sensitivity CRP levels are associated with a higher risk of heart disease. Again, the test is useful for evaluating inflammation, and it's particularly looking at blood vessel inflammation. That's what contributes to atherosclerosis that can lead on to either a heart attack or a stroke, for example. How do we stratify our risk in otherwise healthy people? For people without symptoms or a known history of heart disease, in those cases, high sensitivity CRP can help those folks identify a higher risk of developing cardiovascular conditions. But we generally look for these in people who have a bit more of an elevated risk at baseline, like a family history, for example. If it is elevated, it suggests that you likely have ongoing inflammation that could increase your risk for heart disease. Even, interestingly, if your cholesterol levels are normal. Just as a side note, when I was a medical student many, many decades ago now, I had a professor who said that I don't think cholesterol is the only reason for heart disease. Look at all these people with normal cholesterol. Fast forward a few decades, and sure enough, the latest inflammatory research suggests that, in fact, heart disease is often inflammatory. It can be cholesterol related. It doesn't have to be. Higher CRP levels, these high sensitivity CRP levels, are often linked to worse outcomes in people who already have known heart disease and those who are at higher risk, those with metabolic syndrome, with diabetes, who are overweight, high glucose. Alongside other risk factors, it's most beneficial, as I told you, when it's combined with other risk assessments, which we already spoke about. It does not diagnose heart disease on its own. It gives you a feel for the overall picture. So despite our growing attempts to prevent cardiovascular disease, it's a leading cause of death in the Western world, second cause of death most common worldwide. 30% of all deaths worldwide are estimated to be due to cardiovascular disease. And you hear a whole lot of investment for sure in cancer. That's about 16% of current deaths worldwide. So it's double that. And since the 1980s, high cholesterol is identified as a major modifiable risk factor. But as I just told you, half of all coronary events occur in people who do not have these elevated lipids. Lipid is a cholesterol product. So the surge for better risk predictors has led researchers to try to understand inflammation and novel methods for risk reduction. I think in today's lecture, because today's talk's a big overview, I won't go into the nitty gritty of this, but suffice it to say that people are trying to develop very specific panels that move us beyond cholesterol, CRP, and other inflammatory markers to try to get more precise or precision medicine. And I think that's really what we'll see as we get better, and AI models and such can teach us more as time goes on. So exactly how inflammation plays a role in the heart disease is really not fully understood. It seems to be a relationship to the rupture of a fatty cholesterol-laden plaque in blood vessels, but that's not the only story. That plaque is perceived as foreign, and the body probably makes an immunologic response to it. I always say that everything is inflammatory. I used to tease my cardiology colleagues that everything is rheumatologic in some way, right? Everything has an underpinning of inflammation, all these big diseases. So this perpetuates this inflammatory cascade, and we'll talk about this idea of kindling and fire and how things continue to progress. So inflammation and infection, I just stopped to just talk briefly about long COVID. No doubt inflammation plays a significant role in the development of long COVID. This is a great example of acute inflammation, long-term inflammation. Acute inflammation, those cytokines, you need them unless you have too many of them, then we get into trouble. But the right balance of inflammatory mediators, you want that. You want to heal from the infection. You want your immune defense to be acute and ready, but you don't want it to persist. So the body's immune response to the virus can trigger in some, and this is still very poorly understood, but making strides every day, this idea of a prolonged inflammatory state. And that can affect multiple organs. So this is the idea of having too much of a good thing. Immune system overactivation, cytokine storm. This leads to direct tissue damage. It can damage your heart, your lung, your nervous system. People talk about being unable to calculate the tip on a check. They were mathematicians and cannot do simple math. People are so fatigued they cannot get out of bed, and they have other neurologic symptoms. So there's probably blood vessel inflammation that is chronic, and it's both neurologic and cardiovascular. And I don't have to tell you that there are autoimmune reactions. COVID has spurred on some new autoimmune phenomenon, patients with brand new autoimmune disease that never had it before. And then reactivation potentially of latent viruses may be contributing to this. How about inflammation and cancers? We talked about infection. We talked about heart disease. We'll next move on to cancer. Isn't it incredible that some of the largest diseases, the biggest disease states, every one of them has an inflammatory component? Inflammation encourages the conversion of precancerous tissue to full-on malignancy for many cancers. I already gave you a little of this example, some of these examples at the start of the hour. So inflammation can be involved in initiating the disease, but it can also be involved in advancing metastasis. This is a complicated story of how this occurs. But for example, H. pylori, many of you have heard of that, right? That's the bacteria that's associated with ulcers. If you don't get rid of it and it persists for a long time, it greatly increases your risk for a specific type of gastric stomach cancer. I told you that long-standing ulcerative colitis can lead to colon cancer in a select group of patients who have this for a long, long time. Hepatitis C, fortunately much more treatable these days, but long-standing hepatitis C or places where we don't have as effective treatment can lead to liver cancer when it's there long enough. Infectious pathogens can also generate what are called free oxygen radicals, and they damage our cellular mechanisms. They damage our DNA. So few studies really have shown yet that the inflammatory condition actually alters the DNA itself to provide this initiating spark, but we do know that there is cellular damage. All right, so you're listening on Zoom. It's hard to know how engaged my audience is, so I try to give you a pop quiz, just what you want tonight, right? When was the link between cancer and inflammation? So was it 1863? Was it first realized then? Was it 1963? Was it 2003? Was it just a few years ago in 2013? Well, it was a very long time ago. So in 1863, Rudolf Virchow, who was the first German pathologist who linked inflammation and cancer, he noticed that there were inflammatory cells within tumor that he could see at the microscopic level. So we have known about this link for a long time, and perhaps we underappreciate the great role that inflammation plays in all of these chronic diseases, despite having this knowledge now for centuries. I really like this quote, and I think it's true. That cancer likely begins with our genes or perhaps our environment, those insults. However, if the genetic damage is the match that lights the fire, inflammation may provide the fuel that feeds the flames. So, from history to today, this is sort of how we go from small tumors to larger metastatic disease. So when a small tumor grows, and that's a few aberrant cells, cancer is just unbridled cell growth, it scavenges oxygen and nutrients from its surrounding area. As it grows, though, that demand starts to outstrip its supply. And so as the cells struggle to survive and they accumulate more and more genetic defects, those cancer cells then release chemical signals. That's when they lure your immune system. They essentially tag it and say, come here, there's a problem. And these cellular eaters, those big eaters, those macrophages, and a type of white blood cell called a granulocyte come to infiltrate the tumor. That's what Virchow saw under the microscope in the 1800s. Once inside that tumor, these cells then secrete different molecules. They're called, again, cytokines, that kickstart this growth of blood vessels. Doctors call this angiogenesis, right? To grow vessel. They then shuttle in that oxygen that it's starved for. Those cytokines then, other cytokines, encourage growth of what we call a cellular pillow, which is a stroma against the tumor cells. And then other inflammatory cells are hammering that tumor with free radicals, right? These molecules that damage the DNA. So again, inflammation might also fire the starting gun for metastasis that produces these chemicals that help this cellular tumor bite through the molecules that tether them to the surroundings. Then they're unbridled, right? So together, there is strong evidence, circumstantial evidence at least, that fledgling tumors seem to hijack inflammation, and then that is used to accelerate progression toward full-grown cancer. And so that's the idea, sort of the inflammatory cascade of how it may be contributory to metastatic disease and cancer. So chronic inflammation, as I said, likely impairs our DNA. Mouse models of pancreatic cancer have highlighted that there's acute or self-limited inflammation that's not contributory. So if you have a brief insult, a brief episode of pancreatitis, it does not appear that that in itself is associated with cancer, but repetitive bouts or untreated indeed is. What about arthritis and inflammation? So I give you one example of a rheumatic disease. I think a lot about them as a rheumatologist. So the most common forms of arthritis are rheumatoid arthritis, and then there's ankylosing spondylitis, and then arthritis associated with psoriasis. Not all psoriasis is associated with arthritis, but there is a subset that have psoriatic arthritis. Taking rheumatoid arthritis, we know that there's an increased number of these inflammatory cells and these cytokines within the joint that cause an irritation, swelling of the joint lining, and then eventually what happens is that cartilage is worn down. This is sort of the cushion for the bones. So this local inflammatory response alters the tissue locally and then altering the joint capsule. I'll move on a bit to neurologic disease, and this is incredibly interesting with regard to Alzheimer's disease. So about 6 years ago, it had been appreciated that there's a genetic risk factor, at least one, actually probably quite a few now. One of the most known genetic risk factor for Alzheimer's is a gene called ApoE4. And what is interesting is that not all ApoE4 carriers develop Alzheimer's disease. So this is the argument for whether or not you need to know your genes. Do you want to know you have this or you don't? Because you're not guaranteed that if you carry the gene, you'll go on to develop Alzheimer's. But maybe if you knew you had it, you might want to know that ApoE4 linked with chronic inflammatory states dramatically increases your risk for Alzheimer's. So there's experimental evidence that if CRP levels are repeatedly elevated and you carry the ApoE4 gene, your risk to develop Alzheimer's is magnified versus whether you, in comparison to if you had low and normal CRPs. So this idea of proactive treatment for low-grade inflammation, since many older individuals have chronic low-grade inflammation, right? They suffer from chronic diseases, cardiovascular disease, diabetes, pneumonia, urinary tract infections for sure, certainly after having surgeries or just de novo. So perhaps, as I just mentioned, if you rigorously treat, maybe treating chronic systemic inflammation could be an effective preventative mechanism for Alzheimer's. And I think there is more to be shown here, but I think it's a very provocative model. What about depression? There was a very large scale, over 14,000 people who were in large scale study interviewed in a 5-year period using what's called the Patient Health Questionnaire, the PHQ-9. It's a well-validated screen for depression. And at the same time, they had blood samples drawn. People who had depression, again, this is an association, not causation. People who had depression had 46% higher levels of C-reactive protein. Again, this is not a causative mechanism, but it does confirm that there is an association and begs us maybe to investigate this a little bit more. So again, right, the same model. If depression is a psychoneuroimmunologic disorder, then maybe reducing chronic inflammation in other ways in our body can certainly help mitigate, if not fully prevent, depression. Now I'll talk about, I don't know if it's inflammaging. I think it's inflammaging, right? So this is chronic inflammation's role in aging. I've heard it pronounced both ways. I'll tell you a little more. On the right, you see that this is the reference on the bottom right. But there was a study last year that highlighted that reduced mitochondrial calcium uptake, this is at the cellular level, in macrophages really drives this idea. So I'll talk a little bit about inflammaging. This accelerates tissue damage, and this is what causes this vulnerability to all these chronic diseases. Chronic inflammation becomes persistent with age. So we know as we age, we become a little more inflamed than when we're young. When exposed to invaders or tissue damage, macrophages are these overreactors, right? They drive this. They go to eat that cellular debris thinking they're doing a good thing, and they're the drivers of inflammaging. Inflammaging is linked to heart disease. It's linked to neurodegenerative disease and many, many more. So macrophages are these crucial cells that manage tissue repair. So they're good and they're bad. In age cells, dysfunctional calcium signaling leads to this elevated or heightened inflammatory response. And there's something called NF-kappa B, which is activated and central to the inflammatory gene expression in these macrophages. So this is the target or the pathway that inflammation researchers are looking at carefully, figuring out perhaps if we can modify this. I think a lot about the microbiome. The microbiome is difficult to study and practice, but it's a fascinating story. I'll tell you a little bit about our genes, us versus the bugs. There's something called dysbiosis, and this is true in the gut in particular, but any dysbiosis can cause an inflammatory state. I'll concentrate largely on the gut for this portion of the talk. A dysbiosis is the imbalance in the microbial community anywhere, but for this purpose, we'll talk about the gut. There's a growing evidence that a connection to the gut microbiome itself is possibly precipitating the inflammatory response locally and perhaps more systemically. So this is the microbiome. We ourselves as humans have 10 trillion cells, but the bugs we harbor have 100 trillion, right? So the number of symbiotic microbial cells outnumbers us by a lot, right? So they have 10 times the number of cells. And the approximate number of genes in the human genome is 22,000. The non-redundant genes in your gut, bugs alone, is at least 3.3 million. So obviously this is taking a lot to unravel. But what I thought was remarkable is that as humans, we all look quite different. We share 99.9% of our host genomes. That's shared among each human. But the percentage of individual humans that are the same in terms of their, let's just say their microbiome, that's only about 80 to 90%. That's a big difference. And therefore, shifts or changes in the microbiome may lead us to understand a disease. So the gut microbiota plays a crucial role, helping to regulate our immune function. A healthy gut microbiome then maintains this balanced immune response. The idea is that a balanced gut prevents excessive inflammation. And when the gut microbiome is imbalanced, it leads to this idea of what's been called or termed a leaky gut. This is a increased intestinal permeability. We shouldn't be able to leak through the intestinal wall. But when you do that, harmful substances such as bacteria, toxins can enter the bloodstream. And this is what we believe triggers the systemic inflammatory response. It goes from the gut locally, then systemically, and can be present throughout the body. How does dysbiosis do this? There are two cellular mechanisms that scientists are looking at closely. One is short chain fatty acids. Those are good. And then lipopolysaccharide or LPS. That is bad. So healthy bacteria produce short chain fatty acids, SCFAs, something called butyrate and others. That has a protective effect on the gut lining and the immune system. So when you have this alteration of that and you reduce these short chain fatty acids, inflammation becomes present. Similarly, then when you have more harmful bacteria in this dysbiotic relationship, right, where the good, healthy gut bacteria are reduced and harmful bacteria are increased, they release lipopolysaccharide. This is a component of their own cellular wall, and that crosses into the bloodstream. And then during this intestinal permeability break, where the intestinal lining is no longer tight and becomes permeable again, this is how we think the systemic reactions occur. Okay. So what inflammatory diseases are linked to gut dysbiosis? Well, I told you it's local and systemic. Inflammatory bowel disease, Crohn's disease, ulcerative colitis, the local dysbiosis exacerbates that inflammation in the intestine. Rheumatoid arthritis. There's some suggestions now that dysbiosis influences the onset and maybe the progression of RA by promoting this continual immune system dysregulation. A lot of the immune system is regulated at the level of the gut. And how about metabolic disorders, obesity, type 2 diabetes, and this idea of metabolic syndrome, mainly because inflammation stemming from the gut, as I told you, goes more than local, it becomes systemic and affects insulin resistance as well as fat storage. I think I'm actually skip that. So strategies to prevent and treat inflammation. So we've talked a lot about inflammatory responses in our body, from everything from heart disease to cancer to Alzheimer's to depression. What are we going to do? Well, we can do what we can do. We can't do everything, but we can do some things. So chronic infections, turns out your teeth and particularly your gums are one of the most important things to maintain. There is a lot of evidence, my colleagues included, who have presented this evidence that periodontal disease is strongly linked to rheumatoid arthritis. Periodontal disease has effects well beyond inflammatory gums. Obesity, we talked about. Trying to maintain a normal BMI, but if we can't be perfect, let's at least get progress. A little bit of weight loss decreases our inflammatory burden because it decreases the number of those, helps reduce the fat cell to reduce the inflammatory burden, that little microfactory of inflammation. Reducing alcohol and tobacco use because both of those cause oxidative stress. Again, same thing with radiation. Environmental pollutants. It's controversial, but obviously a more green cleaning chemical is likely better than more industrial toxic chemicals. There's some evidence that high-calorie diets independent of obesity themselves may be inflammatory in their own right. Elevated triglycerides, high blood pressure, and then fasting sugars, which you can test, your doctor can test your hemoglobin A1C, which measures your glucose control over the previous 3 months. This is something that I think one should know, and reducing sugar intake regardless, because sugar is likely one of the most inflammatory chemicals that we currently have available in our environment. I've often said I think that sugar is the next smoking. I think it's a pretty difficult, a pretty toxic risk factor. So a little bit more about what you can do. Okay, this is not shocking to anybody, right? Are foods actually anti-inflammatory? Maybe. They surely seem that they're pro-inflammatory. So I don't think anybody listening to this is shocked that fried foods, soda, refined carbohydrates, lard, and processed meats are likely not to be good for you. So avoiding these as much as possible. The question everybody asks is, what could I eat? I'm going to be very clear here. In medical school in 4 years, I believe that I had exactly 4 hours of dietary education. It's better now, but it's still quite shocking that physicians are taught how to mitigate disease after they already happen. Preventative medicine is still, I think, up and coming. We're doing better. And diet, doctors really just don't have a lot of school in diet. The other reason dietary studies are so difficult to actually do is that you really have to limit people's food. Often you have to give them the food and then you have to track it. And I bet if I polled half of you and asked you what you ate for breakfast on Sunday, you cannot remember. So the problem is dietary recall studies are fraught with information that is potentially untruthful. It's just difficult to do dietary studies. What do I tell people to do with regard to diet? I often recommend what is called an elimination diet. The Whole30 is one type of elimination diet. You can look this up. You can decide what works for you. Essentially, take out foods that are thought to be inflammatory. Again, controversial. Some people swear that gluten is inflammatory even if they don't have celiac disease. My patients often will say, I just feel better if I remove it. Fine. Gluten. Dairy is thought to be inflammatory. Nightshades. So lycopene. There's different vegetables, fruits. You can read about all of them. The Whole30 is a sensible way to take them out of your diet for 30 days, see how you feel. If you feel fantastic, great. Start reintroducing the foods and determine what it was that maybe made you feel worse and eliminate those foods. And then try to aim for the green foods on this slide. So it's not shocking that if the food has a lot of color and looks good for you, it likely is. Obviously, there are mercury and other concerns with fish, but fatty fish in general is a nice source of omega-3. Okay. There's been a systematic review and a meta-analysis. That means it looks at this type of study looks at all of the medical literature by a systematic process and looks at randomized control trials. That means that there was usually a placebo, something that was an inert substance or a different comparator, and a dietary pattern. And they said, can we see if there are particular dietary patterns that have the biggest influence on inflammation and immune-related biomarkers? The Mediterranean diet repeatedly comes through as the dietary pattern that shows the most prominent reductions in inflammatory biomarkers. You saw interleukin-6. IL-6 is one of those pro-inflammatory cytokines. We often measure it for certain diseases. And it, in these studies, was shown to be able to be reduced. And remember our old friend CRP, that also came down. They didn't really see these effects with the DASH diet or vegetarian or vegan diets. Am I going to tell you not to do the DASH diet or be a vegan? Heavens no. It's not like it interfered with inflammation. It just didn't show as robust a response as the Mediterranean diet. And that also had to do with some of the methodology of the study because these are small studies. So I think this requires a little more study, but repeatedly the Mediterranean diet comes up as an anti-inflammatory diet. So I'm confident that I think in recommending that to you, if that is a diet that you are a proponent of, I agree that I believe that's going to continue to show a good effect. Perhaps we'll show a better effect with vegan or vegetarian diets in larger numbers over time. People ask a lot about what you can take. Turmeric or curcumin, that's the sort of the active part of turmeric. I recommend that you get this at a good source. Places like, I do not work for Whole Foods, but natural food stores like Whole Foods where I trust the source. The standardized powder usually comes in the dosing for 400 to 800 micrograms 3 times per day. There's a 1-to-1 fluid extract that you can use. I just want to be really careful with diabetes, gallstones, pre-surgery. Those have some cautionary kind of asterisk. Most of the time, the only time I think that I'm careful about reminding people to stop their turmeric is can act as a natural anticoagulant, a natural blood thinner. So be careful before surgery if it's scheduled surgery. What about weight control? We talked a lot about this. So there's low-grade chronic inflammation when we're overweight. Mice studies, human studies demonstrate that consumption of excess nutrients likely evoke this inflammatory response. The starting signal of inflammation is probably overfeeding, and then the pathway origins and tissues involved in metabolism, like the adipose or fat tissue, liver, and muscle, which is in response to the stimulus that triggers the inflammatory response. There are higher circulating levels of inflammatory cytokines in overweight individuals compared to those with more lean body mass. And the main source of that pro-inflammatory cytokine pool is the fat tissue itself. What about stress? Even childhood trauma. So remember the ACE score is the Adverse Childhood Experience Score. It's a tool that's measuring the number of potentially traumatic events a person experienced. There's 3 categories: abuse, neglect, household dysfunction. This is done in childhood before the age of 18. So if you had stress then, it's linked to a greater risk for all-cause mortality. Includes heart disease, cancer, autoimmune disease, and is thought in itself to be associated with chronic inflammation. You can't go back and redo your childhood, but you can reduce the stress that you have today. So I think this is a surrogate measure for telling us that stress is very, very hard to measure in humans. It's a little bit easier to create in a lab experiment, much harder in human health. But it goes without saying that modifying your stress likely modifies inflammatory response. What about exercise? I only have to look to my 81-year-old father who plays pickleball or tennis many days of the week to know that exercise is a de-ager. I often tell my patients that I believe that exercise is one of the most potent anti-inflammatory meds, I guess, therapeutic options that we have. Exercise is medicine. So recently there was research that suggested that with exercise, there's a natural way to boost the body's immune response to reduce inflammation. I know we are not a mouse, and sometimes mouse studies do not translate to humans, but often they do. And they recently showed, I believe this was last year in Science Immunology, that this is with mice. Acute and long-term exercise mobilized T cells called Tregs, regulatory T cells. These are a type of white blood cells that are key players in the immune system ability to reduce inflammation. So Tregs could help counter exercise-induced muscle inflammation and contribute to improved muscle performance and metabolism. This has been shown, exercise has been shown to lower levels of pro-inflammatory cytokines. There's something called interferon. This comes up when we have a virus, but it also is a chronic inflammation driver, and it's implicated in many age-related diseases. So regular exercise, not episodic exercise, regular, sustained exercise. When they look at like bouts of exercise, better some than none, but keep it on a regular system. I don't know if you can, if I'm on camera to see behind me, but I've moved a small treadmill into my office so I can walk and talk when I don't have to be in front of a computer screen. So regular exercise promotes not only physical fitness, but boosts the immune system's natural ability to control inflammation. I'm going to show you that mouse. These are the hind leg muscles in cross section of a mouse, excuse me, on the right, who lacks those T regulatory cells. So it is bred to lack them. Shows prominent signs of inflammation after regular exercise compared to those from the mouse on the left who has intact Tregs. This research shows that uncontrolled inflammation negatively impacts muscle metabolism. So at least at the mouse, the murine level, these kind of analyses confirm that our immune system, our regulatory cells, our T cells are responsible for broader benefits seen in regular exercises. So animals that lacked those had unrestrained muscle inflammation. There was a rapid accumulation of inflammation promoting cells in their hind legs, as you can see. So their muscle cells also had strikingly swollen mitochondria, which is another sign of metabolic abnormality. So exercise really has systemic effects well beyond our muscle. What are the take-home messages today? I think I'm about 4 minutes over. I'm happy to entertain your questions. Inflammation is your friend and it's your foe, depending on the way in which you harbor it in your body. Internal inflammation detection can be pretty difficult. Sedimentation rates, CRP, maybe in the future other blood tests may help detect inflammation, but you have to use it judiciously in concert with a lot of other things to try to understand the full picture. all of these diseases, heart disease, depression, rheumatologic diseases, dementia, other chronic diseases, even depression are now thought to be linked to inflammation. There appears to be a link between chronic injury or inflammation and certain cancers. And then finally, there are modifiable risk factors to help prevent inflammation. So tonight I'm going to tell you to dust off that treadmill, take your clothes off of it, no longer your clothes hanger, regularly walk on it at least. Walking is fine and more vigorous exercise is great. And I know there are a lot of women joining us tonight, so a little bit of low weights, don't have to be lifting heavy weights, but carrying along some low weights as you walk is also very beneficial. Helps not only with bone health, but decreasing inflammation. I will stop there, and I believe it is time to entertain your questions.
Wonderful. Thank you, Dr. Christopher-Stine. Fantastic information. Yes, we do have quite a few questions. So I'm going to just kind of rattle off two fast ones real fast, just to clarify for Deborah about how much does gluten really matter in terms of inflammation. Just sort of repeat that again.
Yep.
About what your thoughts are on that.
Sure. So I think a lot of doctors assume that if you do not have gluten intolerance, remember gluten is a protein found in wheat as amongst other substances. And doctors always felt, I think, that it's certainly very inflammatory to a gut in which you can't, it's called celiac disease, in which you can't process gluten. That's true gluten-related disease. But many people commented that even though they were not able to rule in celiac disease, so an endoscopy or a blood test didn't confirm, as a matter of fact, it ruled out celiac disease, eliminating gluten still helped them. There's another chemical involved in this called zonulin, and others are trying to figure out why the patients have often told their doctors, there is something about gluten that feels pro-inflammatory to me. Do I think every human should stop eating gluten? No. Do I think that it's reasonable to do a small test of stopping your gluten to see if it makes you feel better? Yes, with this caveat. You need to be eating gluten when you are being tested for celiac disease. I am not a gastroenterologist, but there's a certain amount of gluten. I want to say it's equal to like 2 slices of bread per day for a certain amount of time. So you can't stop eating gluten and then see if you have celiac disease, because you need to see the effect on your intestine. We're looking for certain markers in your blood as well as endoscopic features. But what I was trying to say is that gluten, despite the fact that you might not have true celiac disease, might be an inflammatory or a perpetuator of just feeling unwell. For a lot of my own patients have told me that removing gluten made them feel better. Some people remove sugar and feel better. Certainly removing smoking and losing weight should always make you feel a bit better. But so I just want to be clear about the difference and why gluten may be able to be removed, make you feel better, and you in fact don't have gluten sensitivity in the traditional sense.
Great, thank you very much. So this is a two-parter with Lisa. She'd like to know, so you spoke about exercise and the importance of it, but can too much exercise cause inflammation in the body?
Well, that's a great question. I feel like it was a plant. It's a great question. So Lisa, if I measured your muscle enzymes that shouldn't be leaking into your blood and measured your inflammatory markers after you ran a marathon, certainly after I ran a marathon, I don't even know what it would be because I'm not a marathon runner. If you're a marathon runner and you're a trained marathon runner and I measure inflammatory chemicals in your blood, they're up. So sure. So vigorous exercise, significant exercises, you see people at the end of a marathon, they're not always looking so great. It is an inflammatory response. There is too much of a good thing. However, my patients always say, how much is too much? So none is almost always too little. So, and this is a great, I can give you the rare disease that I study called myositis. Myositis is an inflammatory disease in the muscles where patients are weak. And forever we said, don't do anything. Sit down, rest your muscles. And it turns out people did much worse. They got contracted, meaning that they couldn't unbend their elbows or their knees, and they were weaker. So then we said, there must be some amount of exercise. Each person probably has their own litmus test for how much exercise is too much. So there is an inflammatory response with exercise, but the long-term effects are probably better with continued sustained exercise that is lower level than, you're not going to run a marathon every week. Well, some people do, but that's unusual. So but I hesitate not to tell you to push yourself. So I do think there's some level of doing, some is better than none. Walking, and even if you walk slowly, it's better than not walking at all. But challenging yourself to walk at a brisk pace that might be harder to speak for the person you're walking with, that's okay. If you hurt the next morning, you've probably done a little too much for yourself, but as long as it's not sustained, it's okay. If you cannot get out of bed the next day, you've done much too much for yourself. And so titrating that amount of exercise for yourself is a way to have personalized medicine. So yes, exercise is inflammatory in its own right, but in general, the net positive is that sustained exercise at a reasonable level has anti-inflammatory effects far beyond the immediate pro-inflammatory effects of the exercise itself. Hope that makes sense.
Thank you.
Sure.
Yes, thank you so much. With that said, so what about sleep? So here you are, you're exercising and you're busy throughout your day. And so what's the correlation between, the balance of your everyday activities and exercising and then sleep for recovery? And therefore, can it calm down the inflammation in your body with more sleep?
Yeah. Almost certainly. Interestingly, I'm not aware of any very recent data on sleep, and sleep does everything good for you. So I will just say that I'm all but sure that someone knows the answer to this. I'm not sure that I know any good correlates, but all those good habits, right? So sleep and rest are important in the right ways. Too much sleep is associated probably with a negative effect. So adult women or adults in general, are in general aiming to get 7 to 9 hours. That's being asleep, not just being in bed. I will say that sleep is essentially like defragging the hard drive, right? It's a time where all of our processes, it's a very metabolically active time. So it's interesting that we call it rest, but it probably is not. I think sleep research is in its infancy, but is really coming into its own. I suspect that if I give this talk in a few years, I'll be able to tell you more about it. I would, as a betting woman, I would bet that sleep has at least some signal as having an anti-inflammatory effect, as long as you get enough of it and not too much of it. Yeah, and just on the time of, I'm not a sleep doctor, but I will say that there is a fantastic book on sleep. I don't recall that he touches on inflammation specifically, but all of our homeostasis, right? The way we maintain our body, so that obviously that's part of it, is called Why We Sleep. I'm not remembering the author's name at this moment, but it is a fantastic book. So maybe in there, I'll do my homework, and next time I'll add that slide if I can find the evidence that it's conclusive. Thanks for your question. It's a great one. I'm certain it's probably beneficial.
Great. Thank you very much. Our next question, here's a biggie that's coming from Christina. How much does alcohol matter? What would you recommend for women?
So again, look, I want to be very clear that
I want to know this answer, actually.
So I, like you, sort of keep abreast of the lay press, and I was like, wait, can I have nothing to drink? So again, I was always like, well, don't not too much of a good thing. I don't know. I think this is an evolving question. As you may have heard recently, some people are saying that alcohol is a poison. It's a toxin. It's a muscle toxin for sure. And we know that a lot happens in inflammatory or pro and anti-inflammatory responses at the level of our muscle. So maybe none, but I think we have to make choices. So I would say I'm always sort of kind of in a moderation kind of gal, and that's generally what I recommend, unless alcohol is a problem for you, then it's none. Alcohol is not a problem for everyone. But is it a problem at the cellular level? Maybe. I think that's a TBD. If you want to be perfectly, so at one point, alcohol was supposed to be good for you. I think where we are is that I'm not sure it's truly going to show cardiovascular benefit, but it may not necessarily be bad for you either. It may be neutral. So I think the overemphasis of, hey, a glass of wine or two a night, it's good for you, I think that's being tempered, but I don't know that stopping alcohol altogether is something that every doctor is going to recommend. That's a hot topic. It's a great question. It's topical, and I think it's in flux.
Yeah, I think like you mentioned, just like anything, everything in moderation, right?
I guess
sort of,
almost everything. So
right,
some things you shouldn't,
right. Because,
some things
yeah,
are no, but I think generally yes.
for the
So
most part, yeah.
yeah, so I mean, I
Hopefully.
recommend but there are people that can't, I mean, maybe I can't moderately eat, one brownie. Maybe if you can't moderately drink one glass of alcohol, that's not for you. Right.
Yeah,
So yeah,
exactly. Yeah, mine are peanut M&Ms. So yeah, those
I
are
gotcha.
our trade secrets. Yes.
I feel you right here.
Yeah. Our next question is from Ruth, and she would like to know, so what tests would you recommend based on obesity if you had no symptoms?
CRP. So I think,
CRP.
knowing your CRP for obesity, I'll tell you why. Well, and your doctor is going to say, who said this? But I do think that I'm seeing a bit of a signal in my patients. Why do I say it? I think it's a great motivator and something you can follow besides just losing weight. It's hard to lose weight. And are you really seeing beyond clothes fitting better or an appearance related thing? You're told it's better for you. I think truly CRP coming down is a nice way to show you're decreasing that inflammatory burden. And I have seen CRP lower with a moderate amount of weight loss. Like every patient's like, I have to lose, 40 pounds, 50 pounds. It's like, why don't you lose 5 to 10? Let's start there. And so
Okay.
I think that can serve as a barometer for how much that weight loss is affecting your overall inflammatory burden. If you do not have a high CRP, which I suspect you probably would if obesity is significant. If you don't, good for you. That's rare, but it can happen. But of course, there are still tangible benefits to losing weight for other reasons. But in some cases, it's decoupled to inflammation, and not every obese person has a high CRP.
Great. Thank you.
Sure.
We have a question from Michael. How frequently is inflammation associated with lowering extracellular pH?
Is Michael a biochemist?
He must be. And Michael, that's an excellent question. I
do not know the answer to that, Michael, and I'll ponder and wonder. I mean, obviously, there's, you are, Michael, I'm going to park that and think about it. I don't know how often. Obviously, at the cellular level, you're decreasing oxidative stress, but I don't know off the top of my head any firm data. If they can follow up, just if you tell me why they're asking, I'd be curious. I'm not sure, Michael. I don't know.
All right. We will follow up with that for sure and get back to Michael on that one. Listen, so we just have a couple more minutes. Where do you see research about inflammation going in the future?
Yeah, it's a great question. I think, goodness, science accelerates so quickly. I think what's amazing is that we are going to be able to see a big data with larger modeling. What does that mean? The way that science is often done is individual labs sort of siloed. Yes, we collaborate, but we really can't see big pictures. Example of just as on a small scale of the fact that the vegan diet didn't really show a big signal. It's probably not that eating that way is not healthy. It's that, or maybe it is, but I doubt it. I suspect that it's just not in large enough numbers. I think inflammatory, research will accelerate because we will have things like, I know it's everyone kind of just shudders, but artificial intelligence modeling, ways in which we can see patterns that we can't really just with the human eye alone. So I suspect that putting all of these data points into larger models mathematically with artificial intelligence modeling will be able to show us patterns that we can see. Instead of associations, I suspect that we'll be able to see causality and be able to then investigate, with more precision, the exact cellular mechanisms that maybe we can tweak. And then the final point to that is, why know if it's just an esoteric exercise? I suspect that you will then be able to personalize your inflammatory burden. What I see in the future is a personalized prescription for health, where you know your own inflammatory burden, you know how to reduce it based on your precision medicine platform to tell you that. And that would be my dream for the future.
Wonderful. Well, listen, we're going to have to end it there. Unfortunately, we're getting close to our 8 o'clock hour. I'd like to thank Dr. Christopher-Stine for speaking with us this evening. She has graciously agreed to respond to any unanswered questions that were asked this evening. So, Michael, you have a shot of getting that question answered. And in a couple of weeks, you'll receive an email with answers to any outstanding questions and with the answers. A video of tonight's live stream will be available on the A Women's Journey website, hopkinsmedicine.org/awomensjourney, under Videos on Demand. If you have enjoyed tonight's discussion, please check out our website, hopkinsmedicine.org, A Women's Journey, for more information about live programs, webinars, podcasts, and our monthly email. Also, learn about our annual A Woman's Journey program, which will be on Saturday, November 23rd this year at the Baltimore Marriott Waterfront. So come help us celebrate our 30th year. Good night and stay well.